Now, so that's in the gist why the various reasons why we monitor these patients, why we require them to come back to our clinic and see us regularly. Now, so when they come to our clinic, what do we do? So there are a few tests which we usually do, and like DNA, usually we do not monitor them regularly. We have a level sometime, in some point in time to stage or to put, to categorize the patient, whether the patient is in a replicative state or not. And of course, the ALT will be something where we monitor, and we monitor them every time they come, so that if once the ALT starts to go up, and we screen them for other causes of liver inflammation. For example, some of them may be taking traditional medicine or go for an alcoholic binge or something like that. So in the absence of all those, and if a patient is hepatitis B positive, we'll take it that the patient is going to immune clearance phase. These are the patients which will benefit from treatment, and they'll be channeled to places which will treat them appropriately. Now for HCC development, the two tests, one ultrasound and the other alpha fetoprotein. So ultrasound, we can either specify you want ultrasound the liver or the abdomen, and the alpha fetoprotein, most people will take the lab cutoff. Sometimes you see an alpha fetoprotein of a jump, although it's not very high, from maybe, some people have alpha fetoprotein of maybe 1 point something, 2 point something, and then suddenly it jumps up to about 14, 15. Those are the ones which you get a bit jittery. There are those who are about 11, 12, although they're just a bit off normal. Some of them are actually, that's their usual. But nevertheless, they will require follow-up. Then of course we follow up them for decompensation as well. Now, so most physicians, when a patient comes to you in a clinic, we will require, or we will ask if you can do the liver function test, the alpha fetoprotein, and the ultrasound of the abdomen. So that will literally sort of enable you to look at the patient almost in totality as far as monitoring or follow-up for patients with chronic hepatitis B is concerned. So it is no point doing the DNA all the time, because unless the ALT goes up, especially in young patients, alright, I need to qualify that, especially in young patients, if the ALT remains normal, they can have very high HBV DNA levels. There's no, currently the guidelines do not recommend treatment for these patients as yet, alright. So these are the patients you do not want them to do DNA every time they see you, because it is also very expensive to do the DNA. But there's a group of patients, especially when they are in the 40s, 50s, of a higher age group. They can have normal ALT, but if they have high DNA level, these are the ones which you may want to proceed to do other tests to detect significant liver damage, either the fibroscan, or if the patient is agreeable to go for a liver biopsy. Sometimes you can be quite unpleasantly surprised that the patient has significant liver disease. How often we monitor the patients? It depends on the doubling time and also the risk of developing HCC. So for those patients with advanced cirrhosis with strong family history, you may want to monitor them closer. Most people will recommend 3 to 6 monthly follow-up for this patient. And certainly we need to consider the cost and the compliance to screening. Okay, sometimes you tell a patient as he grows older, the risk actually goes up. And because as he grows older, he gets a bit more complacent as well. Because for the last 5 times when he comes to your clinic, you told him that everything is okay. So you start to skip, and those are the ones which actually get into trouble. So like I said, 3 to 6 monthly, blood test, ultrasound at the same time. And then if these are abnormal, then we proceed to other modality of tests. Sometimes if the ultrasound is abnormal, we want to do a CD scan. Or if the ALT is up, then we'll do the DNA level. So this is my last slide. Chronic hepatitis B, chronic illness, significant morbidity and mortality. We need to monitor them because if you intervene early, early intervention can actually make an impact. It can have a change in the outcome, improve the outcome, and regular follow-up is an established way to detect complications early in these patients. Okay, most 3 to 6 months. LFT, alpha fetoprotein, ultrasound. These are the 3 things that we always talk about. At the start of it, tell your patients this is what to expect. And then once you detect the various endpoints, refer them for appropriate treatment. That's it. Thank you very much.
Thanks, Eng Kiong. We now move to our last speaker, Dr. Louis Hock.